Hello, everyone. Thank you for joining us today for our webinar entitled Meeting the Public Health Reporting Requirements for Medicaid and MIPS Promoting Interoperability. Today's presenter is Bruce Mackey. I'm CETA Regulatory and Incentive Program Analyst. My name is Liz Jones, and I am today's moderator. Before we begin, I have a few housekeeping items to touch on. We will be keeping the phone lines on mute during today's presentation. If you have a question for Bruce, please type it into the questions box in your GoToWebinar interface. We'll take time at the end of the presentation to answer any meaningful use or MIPS program questions you have. If for some reason we are unable to get to all of the questions, we will email you directly with an answer following the broadcast. We will be posting the presentation slides and a recording of today's webinar on our website, www.mceta.org and www.qppresourcecenter.org. Also, the presentation slides are currently available for download in the handout section of your GoToWebinar interface. Today, Bruce will provide you with an overview of the Medicaid and MIPS public health reporting objectives and what it means to be actively engaged with a public health entity. From there, Bruce will review each of the measures within the program's objectives, review Michigan's state-sponsored public health registries, and review when it's appropriate for a participant to claim a measure exclusion. With any time left, he will address questions posed by the attendees during the broadcast. Please note, the information you will hear in this broadcast is current as of today and is only intended to be a general summary. With that, I will turn things over to Bruce.
Thank you, Liz, and thank you everybody for joining me today to walk through the public health reporting objectives of both the Medicaid Promoting Interoperability Program and the MIPS Promoting Interoperability Reporting category. So we have these two programs that have the identical objective, but there are some subtle differences, and that's why we thought it would be good to host this webinar to kind of work through not only what each program contains, but really highlight the differences between the two. Not understanding those differences could put your ability to attest and achieve the reimbursements on the Meaningful Use program and or your Medicare Part B reimbursement rates at risk. So one of those differences is actually in the names of the objectives. So under the Medicaid Promoting Interoperability Program, otherwise known as Meaningful Use, it is called the Public Health and Clinical Data Registry Reporting Objective. Under the MIPS Promoting Interoperability Performance category, it is called Public Health and Clinical Data Exchange. So it's really the exact same objective though. Under both programs, the objective is the clinician is in active engagement with a public health agency or clinical data registry to submit electronic public health data in a meaningful way using certified electronic health record technology, we call that CERT, except where prohibited and in accordance with applicable law and practice. So to meet the objective in either one of these programs, a participant must be something called actively engaged with at least two qualified registries. So what does it mean to be actively engaged? So active engagement has three different options within it. I have them defined on your screen right now. And any one of these options means that you're actively engaged. It does not matter this year which one of these options you're in, as long as you can claim to be in any one of them. So the first option is completed registration to submit data. So the clinician registered to submit data with the public health entity or the clinical data registry to which the information is being submitted. Registration was completed within 60 days after the start of the EHR reporting period. That is a very important component of that. You do, if you're only going to get to option one, you have to have done that within the first 60 days of your 90+ day reporting period. And the clinician is then awaiting an invitation from the entity to begin testing and validation. So it's a fairly low bar to get into option one. As soon as you have registered with that public health entity, you can claim to be in option one. This option allows those clinicians to meet the measure when the entity has limited resources to initiate the testing and validation process. And you only have to do this once, so you don't have to re-register each year. If you have done it in a previous year and you are not yet into option two, that is okay. that active engagement that you achieved initially in potentially a prior program year is still valid this year as well. So option 2 is the next step then. You've gotten into testing and validation. So the clinician is in the process of testing, the testing and validation of the electronic submission of data. So you're oftentimes, the clinician is not necessarily involved in this process. The registry could be working directly with your vendor to kind of fine-tune that messaging. They have to submit some test messages. That's where you might come into play as well, again, where you're relaying those test messages from your vendor to the registry. Every registry is different. I think the EHR vendors is different on how this rolls out as well. But once you get past the registration piece, and as soon as you start working with the vendor and the registry, you're in option 2. I do want to note here, though, that you have to remain actively engaged through this process. So the agency could reach out to you to begin this testing and validation, or they're somewhere in that process. You do have to ensure that you're responding to those requests from the public health agency or the clinical data registry, because if you fail to respond twice within 30 days within your EHR reporting period, the public health agency could kick you out of active engagement, meaning you have stopped responding to those requests and you're no longer actively engaged. That could be reported as such, and then you would not be able to use this registry in either one of these programs. Option 3 then is when you've gotten through that testing and validation and you're actually in production. So the clinician has completed testing and validation of that electronic submission and you're sending live production data to the registry. So any one of these options means you are actively engaged. So there are 5 measures to choose from within this objective. They are the same across both of those programs, and you can actually use each of them more than once. So you're not limited to just one of these measures one time and then have to switch to a different measure for your second registry. There are a lot of registries in each one of these measure options, and you can report to 2 such registries that fall under each one of these categories. So measure 1 is the immunization registry reporting. Measure 2 is syndromic surveillance reporting. Measure 3 is electronic case reporting. Measure 4 is public health registry reporting. And measure 5 is clinical data registry reporting. You can use any one of these measures, and you can use each one more than once if you so choose. From here, I'm going to take a deeper dive into each one of these measures and give you some examples of what's available to you here in Michigan and perhaps nationally as well. So the first one, immunization registry reporting. All of these are yes/no measures. Either you are actively engaged or you're not. So when you go to attest to these, that's all that you're entering. You may be, depending on the program, you may have to choose which one of those 3 options you're in for active engagement. But it's sort of the honor system here. You are just attesting to the fact that you are actively engaged. So for the IMS registry reporting, the clinician attests yes to being in that active engagement to submit immunization data and receive immunization forecasts and histories from the agency. There are some measure exclusions available to you. There's actually 3 that you'll see on the specification sheet for this measure, depending on which program you're in. But 2 of them don't apply here in Michigan. So really, the only exclusion is the first one, where the clinician does not administer immunizations to any of the populations for which data is collected by their jurisdiction's IMS registry. So again, there are 2 other ones, but we do not practice in jurisdictions where those are true. So in Michigan, we have MICR, the Michigan Care Improvement Registry. It is very important to note that you must be actively engaged for their bidirectional connection. It is called, across the industry, it is called QBP, or query by parameter. It is a bidirectional connection. So you are, in previous versions of Meaningful Use, a unidirectional engagement was what got you to be able to claim yes to this registry or to this measure. That is no longer the case in stage 3. It is no longer the case in 2019 MIPS promoting interoperability either. It has to be a bidirectional connection. So many of you have been working with MICR for years and have been using this measure for years. But chances are that was just for their unidirectional option. That is no longer valid for either one of the programs in 2019. So you have to now take an additional step to become actively engaged for MICR's bidirectional connection for QBP. If you have attended any of my prior webinars, I have been hinting at the fact that the state of Michigan or MICR would be handling the registration for QBP through the state's registry website, their management website called HISTR or HSTR. For reasons unknown to us, MICR abruptly changed direction a week or two ago, and they have opted to handle all of the registrations for QBP via email and phone. So I would encourage you all, if you have not already engaged MICR for that bidirectional connection and you want to or need to use the IMS registry reporting measure, reach out to MICR today and get that going. As soon as you send that email to them where you are requesting the onboarding for QBP, that is enough to be able to claim active engagement option 1. You have done that registration piece. Again, you have to do that within the first 60 days of your reporting period, however, which is why I would encourage you, if you have not already done it for this year, for 2019, do it today. Get it done. It's a very low bar. If you can, if you know your MICR site ID, you can get that through the HISTR program. Please include that in that email. It's just going to help smooth things out. You will most likely, when sending that email, you're probably going to hear from somebody by the name of Sally Sims, who is going to handle the registration or the onboarding from there. So yeah, if you, and again, I encourage you to do it today, even if you're not already in your 90-day reporting period, that is okay. It just has to be done by the 60th day of that period. So certainly getting that engagement going sooner versus later is a good idea, whether you're in your 90 days yet or not. Syndromic surveillance reporting is the next measure. So here the clinician is attesting yes to being in active engagement with a public health agency to submit syndromic surveillance data. So syndromic surveillance is essentially an early warning detection system that we have here available in the state of Michigan. It uses the chief complaint that patients are reporting to their providers and sends that data to the state of Michigan. The state of Michigan monitors that data, and it alerts them to outbreaks of certain conditions or diseases, viruses. There's a long list of things that they're looking for. So again, we have multiple exclusions available in a sort of a broad sense, but only the first one is valid for anyone in the state of Michigan, and that is if the clinician is not in a category of providers from which ambulatory syndromic surveillance data is collected by their jurisdiction's syndromic surveillance system. Other states are not as far along with syndromic surveillance as we are, and therefore there are some additional exclusions available, but that don't apply here in Michigan. So in Michigan, we have the Michigan Syndromic Surveillance System, or MSSS. So note that our syndromic surveillance system only accepts data from hospital ERs and urgent care locations. So the vast majority of Michigan clinicians automatically qualify for the measure exclusion because you are not in that category of providers from which our syndromic surveillance system accepts data. So also note, and I have here on the screen, that primary care offices which have after hours or urgent care-like services, that does not count. It has to be either a hospital ER or a legitimate urgent care location in order to be able to connect with this particular registry. So the vast majority of you are going to qualify for that measure exclusion. So the next one is electronic case reporting, where the clinician is again just attesting yes to being in active engagement with a public health agency to submit case reporting of reportable conditions. There are again multiple exclusions here. I didn't actually include the other ones because I needed space on my slide, but so just the first one where the clinician does not treat or diagnose any reportable diseases for which data is collected by their jurisdiction's reportable disease system during the EHR reporting period. There's actually sort of a second exclusion that's not reflected on the measure spec sheet, and I'll get to that a little bit further down the slide. So in Michigan, that's the Michigan Disease Surveillance System, or MDSS. There are some very specific criteria for case reporting. One of them is the data originating from eligible hospitals and eligible professionals. So Michigan's public health code requires that all health provider encounters that result in identification of reportable communicable diseases get reported to the local health authorities. There's a link there on your screen, the michigan.gov/cdinfo. You go there and you can navigate to the long list of reportable diseases that you have to report on here in Michigan. It is quite an extensive list. But you also have to have the capability to submit in the standard format. So there is a national standard that has been developed for case reporting. Your EHR vendor has to be certified to that particular standard. If your EHR is not certified for electronic case reporting, you cannot use this measure, and you would automatically be able to claim a measure exclusion for electronic case reporting. There are, at this time, very few EHRs that are certified to this standard. So out of the top 10, the most popular EHRs out there, right now, only Epic appears to be certified to that standard. The rest of them, as far as we know, are not. So you can touch base with your vendor and to check whether they are certified to that particular standard. You can also navigate to what's called the Chapel website, the site that where the all of the certification information is posted. You can go to that site as well, but you should be able to just touch base with your vendor and figure out if you are certified to that particular standard. So if it is certified to that standard and you treat these particular reportable conditions, then you would have to onboard with this particular registry. So before I get to the next two measures, the public health registry reporting or the clinical data registry reporting, I want to touch on the fact that what we have previously known as specialized registries don't exist in stage 3 or in the 2019 MIPS promoting interoperability performance category. So that used to be its own standalone measure. There was a specialized registry measure, and it was sort of a all-encompassing measure where many registries fell under specialized registry. That has now been divided out into the other two measure options. So all of those specialized registries are going to map to either a public health registry or clinical data registry. So a public health registry are those that are administered by or on behalf of a local, state, territorial, or national public health agency. So think governmental agency. If it is being administered by or on behalf of a governmental entity, whether that's a state government or national governmental agency, that is now a public health registry. The flip side then is clinical data registry, or CDR. These are administered by or on behalf of other non-public health agency entities. So here, think non-governmental entity. So for instance, a lot of medical societies have registries out there. As a medical society, that is a non-governmental entity. So that particular registry, which was previously called a specialized registry, is now a clinical data registry. Okay, so with that determination then, let's roll into what each of these measures are. Public health registry reporting. Again, the clinician is just attesting yes to being in active engagement with a public health agency. So again, think governmental agency to submit data to a public health registry. As we saw on others, there are multiple exclusions, but only the first one applies here in Michigan, because we have a fairly robust public health registry reporting system. There are many options out there. So we are not in a jurisdiction for which no PHA is capable. So the only way you'd be able to claim an exclusion here is if the clinician does not diagnose or directly treat any disease or condition associated with a public health registry in the state of Michigan. So here in Michigan, we have, there are several options available under the PHR measure, such as the Michigan Automated Prescription System, or MAPS. They are in the process of onboarding folks to connect their EHRs directly to the MAPS system. So if you're in active engagement with MAPS for that electronic connection, that could count here. Please note that if you have not engaged MAPS for that electronic connection, the simple website that everybody has and where you're logging in, that would not count. You have to be engaged with them to connect your EHR directly to the MAPS system. We also have the Michigan Cancer Surveillance Program, Michigan Birth Defects Registry, Michigan Birth Registry, and Newborn Screening Registry. So note that one of the state's registries, Michigan's Dental Registry, or MITR, cannot be used in the Medicaid PI program in 2019, as it does not currently use a valid specified standard for data transmission. In 2 slides from now, on slide 12, I'm going to explain that a little bit further so you can understand why MITR cannot be used in the Medicaid PI program. It is okay to use this year in the MIPS program, so that active engagement that you have done previously, or maybe you have started active engagement with them in 2019, that is okay for use in the MIPS program, but it cannot be used in the Medicaid PI program. And again, I'll touch on why in just a couple slides. And also note that similar to the electronic case reporting requirements, if the EHR is not certified for cancer reporting, you cannot engage the Michigan's Cancer Registry. Again, similar to e-case reporting, there's a certified standard out there now, and your EHR has to be certified to that standard, and if it is not, then you would not be able to engage that registry. Clinical data registry reporting. The clinician is attesting yes to being in active engagement to submit data to a CDR. There are multiple exclusions here, and depending on that jurisdiction of the registry itself, all of them may apply. So the first one is the clinician does not diagnose or directly treat any disease or condition associated with the CDR in their jurisdiction. Clinician practices in a jurisdiction for which no CDR is capable of accepting electronic registry transactions in the specific standards. Or the clinician practices in a jurisdiction where no CDR for which the EP is eligible to submit data has declared readiness to receive electronic registry transactions as of 6 months prior to the start of the EHR reporting period. So one example, and there are many, many, many examples out there, would be the PRIME registry. This is one that's sponsored or administered by the American Board of Family Medicine. Again, there are many registries that fall under CDR. If you're looking for a list of some of those registries, I have a link there on the screen for the National Institutes of Health list of registries. You can go there. They have a pretty, it's not comprehensive, but a fairly robust list of available CDRs out there. So to be valid for use, the registry has to meet 3 different criteria. It has to publicly declare readiness to accept electronic data at least 6 months prior to the start of the program performance year, and be able to accept electronic submissions. So manual data entry in a website does not count. A lot of these CDRs have not bridged that gap where they just have a website and you're logging into that website and submitting data that way. That does not count as a valid CDR. They have to be connecting directly to your EHR to be valid for use in this program. They also have to be able to support the registration, onboarding, and production processes. And they have to be able to provide documentation to the clinician as evidence of active engagement. So if they fall short on some of this criteria, it doesn't mean that you can't use them. It really just provides an option to you. The one option they can't avoid is they have to be able to accept those electronic submissions. So again, just logging into a website is not going to count. The whole kind of premise of this measure is that you're connecting your EHR electronically and you're electronically sending that data. So there's not a human entering that data. But if they have kind of fallen short on declaring readiness or falling short on being able to provide that documentation, it doesn't necessarily mean that you can't use them. It's just going to provide an option to you where you don't have to use them, but if you want to use them, you still can. So there's a potential issue under the Meaningful Use Program for Stage 3 with some of the former specialized registries. So as I mentioned a couple slides ago, MITRE falls under this issue. So this is new to Stage 3 requirements and is vital information which only applies to the Medicaid PI, or otherwise known as Meaningful Use participants. This does not apply to the MIPS program. So one of the dividing lines between these two programs is kind of what's left of the Medicare Meaningful Use program has become the MIPS promoting interoperability performance category. They have significantly scaled back on those requirements. However, the Meaningful Use program has stayed firm in those Stage 3 requirements, and this is part of those Stage 3 requirements. So for Measure 4, we pick these up off of the measure specification sheet. For Measure 4, an EP may count a specialized registry, such as a prescription drug monitoring, if the EP achieved active engagement option 3, which is production, in a prior year under the applicable requirements of the PI programs for that year. And for Measures 4 and 5, so this applies to both the public health registry as well as the clinical data registry, if it does not use a specified standard, it must use another standard specified at, you have the regulation there, to meet the measure. For example, that transmission could be in the form of a CCDA or a QRDA. HL7 falls under this as well, but it's got to be using one of these standardized transmission methods to transmit that data to the registry. So we have some translations here. We have worked closely with the state of Michigan so we understand and they understand what these new regulations mean, and you can kind of work through them. So translation for Measure 4 is if the registry is a public health registry or public health agency, if it does not use a standardized method or language for the transmission of data, and you did not attest to being in active engagement option 3, production, in a prior program year, it cannot be used in the Medicaid Promoting Interoperability Program to meet Stage 3 requirements. So again, MITRE is kind of falls victim to this. MITRE does not use at this time, does not use a standardized method for that transmission of data. You're just, I believe, emailing Excel spreadsheets to the registry to submit that data. That does not count. So it falls short of those Stage 3 requirements. Translation for Measure 5. If the registry is a clinical data registry and does not use a standardized method or language for the transmission of data, it cannot be used in the Medicaid Promoting Interoperability Program to meet Stage 3 requirements. So we have a decision tree that we worked with the state of Michigan to build on the next slide that's going to help you make sense of this. You can also download this as a resource in the handout section of your GoToWebinar interface. Again, the slides are there as well. So start at the very top, we'll look at who administers this registry. If it is a governmental entity, again, that is whether it's a state or local, territorial, or national governmental entity, it would fall under that. We're going to ask, are specified standards being used for that data transmission? If the answer is yes, you're good to go. You can use that registry to qualify for the Stage 3 objective. If the answer is no, then the next question is, has the clinician achieved production status in a prior program year? In their attestation, they had to have said yes to being in production in a prior program year. If the answer is yes, then you're good to go. It does not matter that it didn't meet those specified standards. If you've met that production, it would be okay. If the answer is no, the registry cannot be used to meet the Medicaid PI Stage 3 Public Health and Clinical Data Registry reporting objective. So let's go back up to the top and go the other way with it. If it is a non-governmental entity, there's one less question there. Really, the only question is are specified standards being used for data transmission? If the answer is no, you can't use it. If the answer is yes, you can. Here we have a list of all of the Michigan state-sponsored public health options. I've mentioned each one of these throughout on the previous slides. There are hyperlinks to pages where you can learn more about each one of these registries. And the state uses a program or a website called HISTR, or the Health System Testing Repository, to manage all of the different state-sponsored registries. You can register for each of the registries. You can track your progress. You're going to enter a lot of information into those. You can also print active engagement letters out of the HISTR site. So you're going to need that to prove that you have achieved that active engagement with that particular registry. So you can kind of self-serve and print those letters at will from that site. I've got the link to the HISTR site right there. And whether you are kind of new to this, you can create a new account and register for the various state-sponsored registries there, or log in with your existing login and kind of work your way through that whole process. You can use those active engagement letters for either the MIPS or meaningful use program as well. So what must a program participant do prior to claiming a public health measure exclusion? So there's a sort of a minimum effort that has to be made before you can claim a measure exclusion. At a minimum, the clinician has to first determine if the registries offered by the state of Michigan are relevant to the provider scope of practice. You can go back a couple slides to see what those are, but if they're clinically relevant to the participant and you're technologically capable of achieving that active engagement and making that connection to your EHR, you're going to want to achieve active engagement with that registry. Next, you can determine if a medical society with which the provider is affiliated or a member of endorses or sponsors a valid registry for use in these programs. Again, if clinically relevant and technologically capable, you can achieve active engagement with that registry. If no public health registry determination can be made in the previous two steps, the clinician may claim a measure exclusion for one or perhaps both of those required measures. But please note that claiming exclusions works differently between the two programs, and this is a very important distinction. The bar, again, is a little bit lower in the MIPS program. So let's start by running through how exclusions work in the Medicaid Promoting Interoperability Program, or meaningful use. An exclusion for a measure does not count toward the total of two measures. So instead, in order to meet this objective, an EP needs to meet two of the total number of measures available to them. If the EP qualifies for multiple exclusions and the remaining number of available measures is less than two, EP can meet the objective by meeting all of the remaining available measures and claiming the applicable exclusions. So you can't count exclusions toward your two unless you can exclude from 4 or 5 of them, right? If the other measure if you cannot exclude from any 2 of the measure options, then your exclusions are not going to count towards the 2 that are required to meet this particular objective. But if you can legitimately claim enough exclusions where there's less than 2 measures available, at that point, your exclusions are going to count towards meeting the Medicaid PI program objective. The bar is lower for the MIPS PI performance category, however. So the measures under that particular objective are reported using those yes or no responses. The MIPS eligible clinician is going to receive the full 10 points under that objective for reporting 2 yes responses or for submitting a yes for one measure and claiming an exclusion for another. If there are no yes responses and 2 exclusions are claimed, the 10 points get redistributed to the Provide Patients Electronic Access to Their Health Information Measure, otherwise known as the Patient Portal Measure. So here there's a little bit lower bar. As soon as you qualify for 2 exclusions out of the 5 measures, you really have done enough to meet this objective. You can go further and still attest active engagement with measures, which would keep those 10 points under this particular objective. But if you'd like, you could claim two exclusions, and that's it. Those 10 points are automatically going to be redistributed to the patient portal measure, and you can still meet the MIPS PI reporting requirements without any engagement with public health agencies. MIPS eligible clinicians can claim exclusions if they're reporting as a group as well. However, the group as a whole has to meet those requirements for the exclusion. So just because one clinician in the group can claim the exclusions, you would need all clinicians in the group to be able to qualify for those exclusions in order to use that measure exclusion. We've got a bunch of resources here. The top two, the Michigan Medicaid PI program website at michiganhealthit.org and the CMS QPP website at qpp.cms.gov, really contain all the rest of the resources below it, but I do highlight some very important ones as well that will be helpful to you as you work your way through these programs. From the overall Medicaid PI reporting requirements that are available at cms.gov. We have the PI measure requirements. The specification sheets are very important, not just beyond the public health measures, but all the rest of them that are contained within Medicaid PI or MIPS PI. So we've got links for you there. The EP guide for the Michigan Medicaid program is there. And then the history website is there, as well as the reporting options that appeared for the state of Michigan a few slides ago as well. So if you're struggling at all in either of these programs, please know that we are here to help with grant-covered services. So for the Michigan Medicaid Promoting Interoperability Program, you might know us as AMCEDA, the Michigan Center for Effective IT Adoption. We are the federally designated regional extension center for health IT for the state of Michigan, and we are still being funded by Michigan Medicaid to be out there helping you with dedicated in-office technical assistance. So for only $200 per clinician, that's going to get you one of my very talented colleagues to be right in your office working with you side by side to get you to meaningful use. We know that stage 3 of meaningful use is a beast. It is a very hard program to meet these new requirements that are mandatory in 2019. So you do not have to do this on your own. You give us $200, the state of Michigan is paying the other 97% of that fee, so it is a fantastic deal. And we have a vested interest in seeing you achieve stage 3 of meaningful use, because we're not going to see all of that money from the state unless we get you there. So we are going to work tirelessly to get you to stage 3. If you are interested, you can ping us at mceda.org. We've got the phone number there. We have our email address. You can also email me directly. I am happy to help you on board with our grant-covered services for meaningful use. On the flip side, the Quality Payment Program, or you might know it as the MIPS program, you would know us as the QPP Resource Center for the Midwest. Altarum is leading a 7-state collaborative covering the entire Midwest and really beyond, with free remote and web-based technical assistance for small practices. So if you are a small practice, which is defined as 15 or fewer clinicians, we can help you for free. We don't have the in-office technical assistance, but we are doing everything through our website, through the qppresourcecenter.org. We can help you with customized project plans and resources. It's going to give you access to a fantastic team of subject matter experts in this program. It also gives you free access to something called MIPScast, which is our proprietary MIPS scoring tool. We know how CMS comes up with your MIPS final score, and we've built a program, sort of a sandbox to help you, where you can submit your data, whether you're uploading it electronically or keying it in. We're going to tell you exactly what your MIPS final score is going to be. So you can give us multiple sets of data, and we're going to help you kind of work through what is a very confusing scoring option, especially in the quality category. And we're going to tell you which data set's going to give you the best MIPS final score. Another great reason to connect with us is now for 2019, we are now also a CMS qualified registry. What that means is for 2019 data, we can submit that data to CMS on your behalf. So you can work with us to determine what's going to get you the best MIPS final score, and then tell us which data set you want passed on to CMS, and you're done. We're going to submit that to CMS on your behalf, and your MIPS reporting requirements are taken care of. That is also free for those small practices, 15 or fewer billing clinicians. You can get to us at our website, qppresourcecenter.org. We've got the phone number there as well as an email. And again, just like for meaningful use, you can ping me directly, and I'm happy to get you connected into this grant-covered service as well. With that, thank you so much for joining, and I'm going to look at any questions that have come in. I see a couple have come in while I've been presenting. If you have additional questions for me, please put them into the GoToWebinar questions box right now. You can also ping either program with your questions, and you are always free to get a hold of me. You've got my email and phone number on your screen right now as well. So if you think of a question later, feel free to ping any one of these options, and we're going to make sure that we get you your answer. So one question that has come in. I just went live with bidirectional. Will that be accepted for 2019 reporting? Absolutely. So again, as long as you're actively engaged with MICR for that bidirectional connection, whether it's option 1, option 2, or option 3, you have done enough in the program for this year to be able to claim that active engagement for the immunization registry reporting measure. A question that always gets asked, will the slides be sent to us later? You can grab those right now. They are available in the handout section of your GoToWebinar interface. We will also be posting them to each of the websites that are on your screen right now. I will not be sending them out directly to you, so feel free to just download them right now from your handout section or navigate to either one of these websites later, and they will be available. On slide 13 are all the state of Michigan registries using standards for data transmission. No. So as I mentioned earlier, MITRE is the one registry that the state of Michigan sponsors that has not yet bridged that gap. So MITRE does not meet that requirement to use a standardized transmission language for that transmission of data to the registry. So other than that, yes. But the MITRE is the only state registry that does not meet stage 3 meaningful use requirements. Again, it can be used under the MIPS program. As we've seen in the MIPS program, they are significantly relaxed requirements and objectives there, and that is one area that did not see that bar get raised. So you can use MITRE under the MIPS program, but you cannot use MITRE under meaningful use. The last question I have so far, I believe has come to me via email as well, but we'll address it here. So it says, in 2018, our EHR, NextGen, was in production with the WellCentive and NPO registries. At the end of 2018, we moved over to Cerner, and we have yet to get that into production. Can we claim active engagement after we were previously in production? So the WellCentive and NPO registries are going to fall under CDR. So it's for stage 3 requirements, we're going to go back to that decision tree. So these are non-governmental entities. So they have to be using specified standards for that data transmission. So you'll have to talk with WellCentive as well as NPO. We can kind of help with that as well, but they may not be. I don't believe NPO is using a specified standard for their particular registries. So in terms of meaningful use, you're not going to be able to claim, you're not going to be able to use those under the meaningful use program. Again, they would still potentially work under the MIPS program, however, because only the meaningful use has that raised bar for the CDRs. That appears to be it in terms of questions thus far. So I get to give you 15 minutes back to your day. How's that for a change, huh? I usually go over on my webinars. So I'm going to give you 15 minutes back again. Please feel free to contact me directly if you have any additional questions. You can also ping each of the programs. We have a great team of colleagues I work with manning the email and phone lines for these two programs, or contact me directly. With that, thank you so much for joining me today. I look forward to speaking with you more and look forward to seeing you on future webinars. Have a great day.